I'm glad to see you. My dear, we have now adrenergic system and adrenergic drugs, adrenomimetic and adrenoblocker. No, what is it, adrenergic transmission? You know it, but it show place. Adrenergic transmission is restricted to the sympathetic division on the autonomic nervous system. There are three closely related endogenous catecholamines. Noradrenaline, it acts as transmitter at postganglionic sympathetic site. No, except sweat glands have follicles and some vasodilator fibers. And in central areas of brain. Adrenaline, it is secreted by adrenal medulla and may have a transmitter role in the brain. And dopamine, it is major transmitter in CNS, basal ganglia, limbic system, etc., and in a limited manner in the periphery. But you know it, noradrenaline, adrenaline, and dopamine. You must know very nice synthesis of catecholamines. Catecholamines are synthesized from the amino acid phenylalanine. Phenylalanine in liver are synthesized to tyrosine and later into DOPA, and DOPA decarboxylase may cause dopamine, and dopamine beta oxidase may cause noradrenaline. This synthesis in adrenergic neuronal cytoplasm. Noradrenaline inside granules maybe, and adrenaline in adrenal medulla cells are finally top of synthesis of catecholamines. It's very important, synthesis of adrenaline occurs only in the adrenal medulla cells. No, you know it, yes. You must know storage of catecholamines. Noradrenaline is stored in synaptic vesicles or granules within the adrenergic nerve terminal. The granular membrane actively takes up dopamine from the cytoplasm, and the final step of synthesis of noradrenaline takes place within the granule. The cytoplasmic pool of catecholamines is kept low by the enzyme monoamine oxidase, present on the outer surface of mitochondria. Release of catecholamines. The nerve impulse, coupled release of catecholamines takes place by exocytosis, and all the granular content, noradrenaline or dopamine, are purged out. The release is modulated by presynaptic receptors. About presynaptic receptors later is very important for therapeutic uses. Drugs which act on presynaptic receptors may cause very strong effect on organs. Uptake of catecholamines. This occurs in two steps. First step, external uptake. In active amine pump is present at the neural membrane, which transport noradrenaline at a higher rate than adrenaline. This uptake is the most important mechanism for terminating the postjunctional action of noradrenaline. And granular uptake. The membrane of intracellular granules has another amine pump, which transport catecholamines from the cytoplasm to within the granule. It is very important in maintaining the noradrenaline content of the neuron. You must know metabolism of catecholamines. In metabolism of catecholamines are participated two enzymes, monoamine oxidase intracellular and catecholortomethyltransferase, which extracellular, and catecholortomethyltransferase in plasma of our vessels, and all adrenomimetic may be metabolized by catecholortomethyltransferase. Monoamine oxidase intracellular enzyme, very specific for noradrenaline, adrenaline, and dopamine. No, but major important information of adrenoceptors. You must know it very nice. Adrenergic receptors are membrane-bound G-protein couplet receptors, which function primarily by increasing or decreasing the intracellular production of second messenger, CMP or IP3DG. You know it from autonomic nervous system general structure, but I repeat, it's very important. In some cases, the activated G protein itself operates potassium or calcium channels. All adrenergic receptors are classified in two types, alpha and beta. You must know important features of alpha and beta receptors. All information is very important. Alpha 1. Agonist noradrenaline as neurotransmitter in alpha 1 adrenergic synapse. Effector pathway IP3DG, you know it. You must know very nice location of alpha-1 adrenergic receptor and effect of action. It is all type of pharmacology alpha-1 adrenergic receptor. Location alpha-1 only postjunctional on effector organs, not prejunctional, only postjunctional. The major important blood vessels. But blood vessels in cutaneous, mucous membrane, renal, all blood vessels except in skeletal muscles, heart and brain. These blood vessels have beta-2 adrenergic receptor, about it later. Stimulate alpha-1 receptor in this location may cause vasoconstriction and rise in BP. Vasoconstriction and rise in BP in systolic, diastolic, and mean BP. Spleen capsule has alpha-1 receptor 2 and stimulate alpha-1 receptor on splenic capsule may cause contraction and rise in BP 2. Radial muscles of iris. Contraction in radial muscles of iris may cause mydriasis, but without cycloplegia, in contrast, collina blocker, yes? But the intraocular tension tends to fall, in contrast, M-collina blocker. M-collina blocker, atropine may cause mydriasis and to increase intraocular tension. But in these cases, intraocular tension tends to fall, especially in wide-angle glaucoma, because vasoconstriction in eye results in decreased aqueous formation, and uveal scleral outflow may be increased. That's why mydriasis. But vasoconstriction in eye result in decreased aqueous formation. Smooth muscles stimulate alpha-1 receptor on smooth muscles may cause contraction of the intestinal sphincter. Very strong effect. And location alpha-1 on heart is not very important. Little action, maybe little bradycardia, arrhythmia, only in high dose. It's alpha-1 adrenergic receptor. You must know it very nice. Alpha-2, agonist noradrenaline, similar alpha-1. Effector pathway inase, G-protein inhibitory and decrease CMP pathway, but decrease CMP. Location may be pre-junctional and post-junctional. Pre-junction location may cause effect of action as inhibition of noradrenaline release from nerve terminal. It's very important effect. A lot of drug stimulate or inhibition pre-junctional beta alpha-2 receptor and inhibition or stimulation noradrenaline release from nerve terminal. And post-junctional on effector organs. First, major important, insulin secretion. Stimulate alpha-2 adrenergic receptor may cause inhibition insulin secretion. It may be very strong adverse effect of the drugs. Blood vessels, specific in nasal. It's very important, specific in nasal, and stimulate alpha-2 adrenergic receptor may cause constriction blood vessels in nasal. And smooth muscles stimulate alpha-2 adrenal receptor in smooth muscles, may cause intestinal relaxation. Beta-1, agonist dopamine, not noradrenaline, dopamine. Effector pathway, G-protein stimulatory, and increase CMP. Stimulation effect. Location and effect of action. Location beta-1 only post-junctional, and very important on heart. Stimulate beta-1 adrenal receptor of heart may cause cardiac stimulation, increase rate, force, conduction velocity. Second location, kidney. Stimulate beta-1 receptor on kidney may cause renin release from kidneys. Beta-2, agonist dopamine, effector pathway, G-protein stimulatory, and increase CMP, similar beta-1. All beta receptors have this effector pathway. Location and effect of action may be pre-junctional and post-junctional. Pre-junctional, stimulate beta-2 pre-junctional receptor, may increase noradrenaline release from nerve terminals. Blockade beta-2 pre-junctional may inhibit noradrenaline release from nerve terminals. Post-junctional, blood vessels, skeletal muscle, in heart, in brain, may cause dilatation of arterioles and veins. Stimulate beta-2 adrenergic receptor in these blood vessels, may cause fall in BP, very strong fall in BP. Smooth muscles stimulate beta-2 adrenergic receptor on bronchi, may cause bronchodilation. Very effective, this drug in treatment of bronchial asthma. Stimulate beta-2 adrenaline receptor in gastrointestinal tract may cause intestinal relaxation. Very effective therapeutically. Stimulate beta-2 adrenaline receptor in uterus may cause uterus relaxation and bladder detrusor relaxation. In liver, beta-2 receptor may stimulate beta-2 receptor may cause increased glycogenolysis. It may cause hyperglycemia. All beta-2 adrenergic drugs may cause hyperglycemia. It's very strong adverse effect, very dangerous of diabetes drug, diabetes patient. Beta-2. And last type of beta receptor, beta-3. Beta-3 agonist dopamine, similar beta-1, beta-2, affect the pathway G protein stimulator and increase CMP, similar beta-1, beta-2 adrenal receptor. Location and effect of action. Location only postjunctional on effector organs and only on fat. Effect of action stimulate beta-3 receptor on fat, may cause lipolysis and increase blood-free fat acid. It's not very important for therapeutic practice, but maybe. Adrenergic drugs, classification. Adrenergic drugs or sympathomimetics. These are drugs with action similar to that of adrenaline or sympathetic stimulation. Adrenergic drug may be direct sympathomimetics, indirect and mixed. Direct sympathomimetics, adrenaline, noradrenaline, isoprenaline, phenylephrine, salbutamol, and many others. They are directly as agonist on alpha and or beta adrenoceptors. Second group, indirect sympathomimetics. They act on adrenergic neuron to release noradrenaline, which then acts on the adrenoceptors. It's only tyramine precursor of noradrenaline. Mixed action sympathomimetics, they act directly as well as indirectly. It's ephedrine, amphetamine, and others. Classification of adrenergic agonist may be by receptors which uses this drug. Maybe alpha adrenomimetics, it's very important, alpha adrenomimetics. Phenylephrine, only alpha-1. Xylometazoline, only alpha-2. Very selective drugs and another effect in clinic. Beta adrenomimetic, non-selective, beta-1, beta-2, without beta-3 receptor. On beta-3 receptor may cause effect only adrenaline as commons of our body. Beta-1, beta-2, isoprenaline or cyprenaline. Beta-1 selective, dobutamine, only beta-1, but dobutamine is not cardiostimulant, it is cardiotonic, inotropic, about it later. Characteristic dopamine later. Beta-2 selective adrenergic drug, salbutamol, terbutalin. Alpha-beta adrenergic drug, direct sympathomimetics, adrenaline, noradrenaline, ephedrine, but ephedrine mixed action, has direct and indirect mechanism of action. And dopamine. Dopamine, it is dopamine D1, D2, as well as adrenergic alpha and beta 1, but not beta 2 agonist. Very specific drug. It is mediator, and we have drug dopamine. No, about another drug, specific drugs. Phenylephrine. You must know all information about phenylephrine. It is selective alpha-1 agonist. It raises BP and peripheral resistance by causing vasoconstriction. It has little cardiac action. No, reflex bradycardia maybe. That's why very strong increases BP. Reflex bradycardia. It is also used as a mydriatic when psychoplegia is not required. It tends to reduce intraocular tension by vasoconstriction action. It should be used as pressure agents and nasal decongestants. Produce local vasoconstriction in nasal. Phenylephrine is resistant to metabolic degradation by monoamine oxidase. Resistant. Isoprenaline. It is beta 1, beta 2 agonist. It increases the automaticity of the sinoatrial node, rate, force, and conduction velocity in heart. It relaxes bronchial smooth muscles. It should be used as bronchodilators and cardiac stimulants. The most side effects, tachycardia and the increasing blood sugar. Next drug, dobutamine, selective beta 1 agonist. It increases force of cardiac contraction without significant change in heart rate, peripheral resistance, and BP. Only force. It has been used as an inotropic agent or cardiotonic agent in pump failure accompanying myocardial infarction, cardiac surgery, for short-term management of severe congestive heart failure. It is less arrhythmogenic. Dopamine has few adverse effects. Noradrenaline. Noradrenaline is neurotransmitter in adrenergic synapse, but we have noradrenaline as drug, therapeutic drug. It activates both type of alpha and beta 1, but not beta 2 receptors. It causes hypertension, increases systolic, diastolic pressure, and peripheral resistance. It often causes arrhythmia and do not causes relaxation of bronchial smooth muscles. Not increases blood sugar and other effect of beta 2 receptor. It should be used only as a pressure agent, only, but very strong pressure agent. Adrenaline. It has potent action on both subtypes of alpha as well as beta receptor. It increases heart force and conduction velocity. It increases BP. It rises BP, rises BP, increases systolic pressure, but decreases diastolic pressure and peripheral resistance. That's why stimulate alpha-1 receptor may cause increase systolic pressure, but stimulate beta-2 receptor in skeletal muscle may cause decreases diastolic pressure and peripheral resistance. That's why a lot of vessels in skeletal muscle. It is potent bronchodilator. It is relaxes the trusor of the bladder. It constricts its sphincter, sympathetic tone. In eye, it causes mydriasis and decreases the intraocular tension. That's why it may cause constriction vessels in eye and production of intraocular water. Uses. Adrenaline should be used as cardiac stimulant and bronchodilator. It can be used to treat anaphylactic shock and treat glaucoma. Adverse effect. Adverse effect of adrenaline, tachycardia, and ventricular arrhythmias, hypertension, the increasing blood sugar, and cerebral hemorrhage. Very important for us is therapeutic classification of adrenergic drugs. Pressure agents, alpha-1 agonists. It's noradrenaline, but we know that noradrenaline alpha-beta adrenaline mimetic. Ephedrine, alpha-beta adrenaline mimetic, but alpha-1 effect very strong. Dopamine, alpha-beta adrenaline mimetic, but alpha-1 effect very strong. And phenylephrine, selective alpha-1 adrenaline mimetic. Cardiac stimulants, we have beta-1 agonists, adrenaline, alpha-beta adrenaline mimetic, isoprenaline, beta-1, beta-2 adrenaline mimetic, ephedrine, alpha-beta adrenaline mimetic, dobutamine, very strong beta-1 adrenaline mimetic, but not cardiac stimulants, it is cardiotonic, inotropic. Later, bronchodilators. Bronchodilators must be beta-2 agonists. Adrenaline, alpha-beta adrenaline mimetic may be used as bronchodilator. Isoprenaline, very strong bronchodilator, not only cardiostimulant. Ephedrine, very strong bronchodilator. But salbutamol and terbutaline, selective beta-2 adrenergic agonist, that's why the most important for treatment of bronchial asthma without a lot of adverse effects on blood sugar, on heart and other, yes, hypertension and other. And nasal decongestants, alpha-2 agonists. Ephedrine has this effect, alpha-1, alpha-2 may be used as nasal congestants. Pseudoephedrine, similar. And very specific, xylometazoline, only alpha-2, very specific alpha-2 agonist. Xylometazoline may be named galazoline, naftazine, you know this drug. Ephedrine. I wish about ephedrine little words. It is an alkaloid obtained from Ephedra vulgaris. Primarily, it acts indirectly, increases noradrenaline release from nerve terminal. but has some direct action on alpha and beta receptors also. Repeated injection produced tachyphylaxis, absence of effect. That's why noradrenaline increases, or sorry, ephedrine increases noradrenaline release and no effect, uh, no dependent of dose of drug, not effect. It is resistance to monoamine oxidase and therefore effective orally. It's very important for clinic, yes, very like for patient. It is about 100 times less potent than adrenaline epinephrine, but longer acting, 4-6 hours, and therefore sometimes used prophylactically in chronic treatment of asthma to prevent attacks rather than to treat the acute attack. It crosses to brain and causes a mild stimulation of the CNS. It also improves athletic performance. Ephedrine can be used to treat postural hypertension, bronchial asthma, and as a nasal decongestant due to its local vasoconstrictor action. But we must think about tachyphylaxis. Only one time may be used ephedrine. Adverse effects. Ephedrine may cause CNS disturbances. It can produce hyperactivity, insomnia, maybe nausea, vomiting, tremors, anxiety, fear, tension, very strong headache, tremors too. Hemorrhage. The drug may induce cerebral hemorrhage as a result of marked elevation of blood pressure. And cardiac arrhythmias, tachycardia maybe. The clinical use of ephedrine is declining due to the availability of better, more potent agents which cause fewer adverse effects. Ephedrine is narcotic, very strong psychostimulant. No, it's picture, only picture. Adverse effect ephedrine, arrhythmia, tachyarrhythmia, hyperactivity, very specific for athletes, yes. Doping, first doping. Ephedrine was first doping. Very strong headache may cause ephedrine. Insomnia, yes. That's why stimulant of central nervous system. Nausea may be very strong nausea, central nausea, tremors. That's why stimulant of CNS. And last drug, adrenomimetics, dopamine. It is a dopamine D1 and D2, as well as adrenergic alpha and beta 1, but not beta 2 agonists. The D1 receptors in renal and mesenteric blood vessels are the most sensitive. Intravenous infusion of low doses of dopamine delays these vessels increasing. High doses produce a positive inotropic beta 1 action, but little chronotropic effect on heart. It's very important for cardiac failure. Vasoconstriction alpha action occurs only when large doses are infused. It has prophylactically no effect on non-vascular alpha and beta receptors. It does not penetrate blood-brain barrier, no CNS effect. Dopamine is used to improve renal blood flow and BP in patients of shock, mostly cardiogenic shock, and as inotropic agent in treatment of congestive heart failure. Adverse effects. An overdose of dopamine produces some effects as sympathetic stimulation. Dopamine is rapidly metabolized, and its adverse effects, nausea, hypertension, maybe arrhythmias, are therefore short-lived. It's enough. Adrenergic blood drugs include not only adrenomimetics, plus adrenergic blocker. Classification. We have alpha adrenergic blocker, beta adrenergic blocker, and sympatholytics. Alpha blocker may be non-selective alpha-1 and alpha-2. It's phentolamine. And very selective, only alpha-1, prazosin. Beta blocker may be non-selective, beta-1, beta-2, but A, without intrinsic sympathetic activity, propranolol, with intrinsic sympathetic activity, pindalol, with additional alpha-blocking property, labetalol. And cardioselective, only beta-1, atenolol, metoprolol. Drug affecting neurotransmitter uptake or release, or sympatholytic. It's rezepine and cocaine. Alpha-adrenergic agent. These drugs block alpha adrenoceptors, profoundly affect blood pressure. Since normal sympathetic control of the vasculature occurs a large part through agonist action on alpha-adrenergic receptors. Blockade of these receptors reduces the sympathetic tone on the blood vessels, resulting in decreased peripheral vascular resistance. This induces a reflex tachycardia, resulting from the lowered blood pressure. Phentolamine. It produces a competitive block of alpha-1 and alpha-2 receptors and increases noradrenaline release from nerve terminal. That's why block alpha-2. Stimulate alpha-2 prejunctional receptor may cause inhibit release noradrenaline from nerve terminals, but blocks this receptor may cause increases noradrenaline release from nerve terminals. It causes fall in BP and may cause reflex tachycardia. It may increase intestinal motility because alpha blocker inhibits relaxant sympathetic influence. Phentolamine may cause diarrhea. Diarrhea may occur. It has been used as a quick and short-acting alpha blocker for first, diagnosis and intraoperative management of pheochromocytoma. It is tumor of adrenal medullary cells, which can secrete adrenaline into blood. And second, peripheral vascular disease, Raynaud's phenomenon, acrocyanosis, etc. It's picture about mechanism of action of phentolamine. Phentolamine stimulate prejunctional alpha to adrenal receptor and make block prejunction alpha, not stimulate block alpha to prejunctional receptor, and may cause stimulate release noradrenaline from items, nerve items, and block postjunctional alpha 1, alpha 2 adrenoceptor on organs. Prazosin. It is selective alpha 1 adrenergic blocking agent. It doesn't increase noradrenaline release because don't affect on prejunction alpha 2 receptor. It produces falling BP, which is attended by only mid tachycardia. It is primarily used as an antihypertensive drug. Adverse effect of this drug: tachycardia, reflex tachycardia in orthostatic hypotension. That's why orthostatic hypotension. Maybe vertigo and sexual dysfunctions. Beta-adrenergic blocking agent. These drugs lower blood pressure in hypertension. They do not induce postural hypotension because the alpha adrenoceptors remain functional. Therefore, normal sympathetic control on the vasculature is maintained. Beta blockers are also effective in treating angina, cardiac arrhythmias, myocardial infarction, and glaucoma, as well as serving in the prophylactic of migraine headache. Prototype of group, the drug of propranolol. Action. It is non-selective beta-1, beta-2 adrenergic blocker. It decreases heart rate, force of contraction, and cardiac output. Total coronary flow is reduced. Blockade of delayed beta-2 receptors. But this is largely restricted to the subepicardial region, while the subendocardial area, which is the site of ischemia in angina pectoris, is not affected. Overall effect in angina patients is improvement of oxygen supply to demand status and exercise tolerance in increased. Propranolol causes fall in BP. It hasn't direct effect on blood vessels. Total peripheral resistance increased initially due to blockade of beta-2 mediated vasodilation. It is little change in BP. Its antihypertensive action may contribute to reduced noradrenaline release from sympathetic terminals due to blockade of beta-2 prejunctional receptor. It is major important mechanism of antihypertensive action of propranolol. But plus decreased renin release from kidney due to blockade of beta-1 receptors. Plus decreased heart rate and force due to blockade of beta-1 receptor on heart. And central action, reducing sympathetic outflow. Propranolol may cause sedation and may cause inhibit central action sympathetic outflow. Therapeutic effect and use. Propranolol lowers blood pressure in hypertension. Propranolol and other beta blockers are effective in diminishing intraocular pressure in glaucoma. This occurs by decreasing the secretion of aqueous humor by the ciliary body. Many patients with glaucoma have been maintained with this drug for years. They neither affect the ability of the eye to focus to near vision, nor change pupil size as do the cholinergic drugs. However, in an acute attack of glaucoma, pilocarpine is still the drug of choice. The beta blockers are only used to treat this disease chronically. Propranolol is also effective in reducing migraine episodes and may be used in the treatment of chronic migraine. The mechanism may depend on the blockade of catecholamine-induced vasodilation in the brain vasculature. Propranolol decreases the oxygen requirement of heart muscle and therefore is effective in reducing the chest pain and is useful in the chronic angina. Propranolol and other beta blockers have a protective effect on the myocardium. Thus, patients who have had one myocardial infarction appear to be protected against a second heart attack by prophylactic use of beta blockers. Adverse effects. Bronchoconstriction. It is potentially lethal side effect when administered to an asthmatic. Therefore, propranolol must never be used in treating any individual with obstructive pulmonary disease. It is very strong contraindication for propranolol. Bronchial asthma is contraindication for using of propranolol. Arrhythmias. Treatment with the beta blockers must never be stopped quickly because of the risk of precipitating cardiac arrhythmias, which may be severe. Several. Sexual impairment. Since sexual function in the male occurs through alpha adrenergic activation, beta blockers do not affect normal ejaculation, nor the internal bladder sphincter function. On the other hand, some men do complain of impaired sexual activity. Disturbances in metabolism. Propranolol leads to decreased glycogenolysis and decreased glucagon secretion. Fasting hypoglycemia may occur. Pindalol, antagonist with partial agonist activity. It is not pure blocker. It has the ability to weakly stimulate both beta 1 and beta 2 receptors. And is said they have interesting sympathomimetic activity. Pindalol is effective in hypertensive patients with moderate bradycardia because it decreases in heart rate less. It's very important for Pindalol therapeutic situation. Labetalol, alpha and beta blocker. It is a reversible beta blocker with concurrent alpha 1 blocking actions that produce peripheral vasodilation, thereby reducing blood pressure. Labetalol thus contrasts with the other beta blockers that produce peripheral vasoconstriction, and it is therefore useful in treating hypertensive patients for whom increased peripheral vascular resistance is undesirable. And last drug in our lecture, reserpine. Drug affecting neurotransmitter uptake. Reserpine, a plant alkaloid, blocks transport of biogenic amines, noradrenaline, dopamine, from the cytoplasm into storage vesicles at the adrenergic neuron. Since monoamine oxidase can degrade noradrenaline in the cytoplasm. The drug has a slow onset of action and a long duration of action. When one stops taking the drug, the action persists for many days. It can be used as antihypertensive, only antihypertensive drug. Adverse effect which may cause reserpine. It's bradycardia, hypertension, fatigue, drowsiness. It's enough today.